2018, which amounts to an additional 220,000 patients screened in 2018 alone. And in 2018, about 31 health centers reached or exceeded an 80% screening rate. But we really need that 80% to be reached in order to save those lives. And while 10 million patients complete fecal testing each year in the United States, the problem is that not all of the individuals who have abnormal tests complete that follow-up colonoscopy. And for these patients, the benefit of screening altogether is nullified. So the diagram on the right here shows that the screening path following an abnormal fecal test isn't complete until that colonoscopy is completed. Patients need to start to understand that as well. So we've been working with the safety net clinics to increase CRC screening by implementing the direct mail fecal testing program. And the project on which we did this was STOP-CRC. And as I mentioned, I'll be referencing this project throughout the presentation. It was the 26 clinics in Oregon and California, and we created this series of electronic health record tools to mail FIT tests directly to the patient. And from our work on STOP-CRC and the work from David List, who we referenced here, we found that only about 52 to 54% of patients who have an abnormal test are receiving their follow-up colonoscopy. And this is a problem because we know that these patients are showing blood in the stool and that the likelihood of detecting the polyps, adenomas, or cancer is high. And this matters because those 1 in 20 patients have colon cancer with a positive FIT. And this literature ranges from 1 in 11 to 1 in 28 individuals with abnormal FIT have CRC, but then the literature also reports that about 1 in 3 to 1 in 7 individuals of those with CRC actually have advanced cancer. So the estimated cost savings for treating a patient with colon cancer is about $310,000. So the earlier we can detect that cancer, remove that polyp, and start early treatment if necessary, the more money the health system saves. So if a colonoscopy is delayed by 6 months or longer, the patient is 31% more likely to get colon cancer. They're about 7 times more likely to die from colorectal cancer, and 2 times more likely to have that advanced stage disease. And according to the most recent literature, this is from Bahardi in the Cancer Journal in 2019 and List, and our own article in JAMA, safety net practices range from 44 to 53% of individuals who screen positive obtain a follow-up colonoscopy. And here's some more literature that show the results of colonoscopy within 6 months in these different articles. And what you see here is that it ranges from about 37 to 51% in these articles. And we know that the goal set by the Multi-Society Task Force on Colon Cancer is to get 80% of these follow-up colonoscopies completed. And some of the data that's not shown here is that oftentimes younger patients obtain their colonoscopy within a year. That's about 59% of younger patients compared to 52% of older patients. And only about 57% complete a colonoscopy within 18 months. So the range doesn't go up that much for a longer time period. These are patients that just aren't getting their colonoscopy. And only 25% of the patients in these studies reported a colonoscopy within 60 days. So we know that colonoscopy can take a long time, especially in safety net practices where you might be referring to a specialist. There might be a wait list, and there might be delays in scheduling altogether. So patients who delay a colonoscopy by 6 months have that 30% increase in incidence and 2-fold higher risk of advanced stage disease compared with those who receive a colonoscopy in 1 to 3 months. And there's been some modeling that shows a 4% increase in CRC incidence and a 14% increased mortality with delays of 12 months or longer. And for that reason, the PROSPER study set their standard at 90 days. So Doug Corley, through the PROSPER project at Kaiser in California, looked at follow-up colonoscopies and found that any colonoscopy greater than 6 months after an abnormal test is increasingly associated with a higher risk of any colorectal cancer and advanced stage disease. And for that reason, we recommend a screening interval of a colonoscopy after an abnormal test within 90 days. So we need to understand some of the reasons behind why there is failure to follow up. And based on our initial chart abstraction of stop-CRC patients with the abnormal FIT test, we found that the majority of the patients really had no reason indicated in the chart for why they were either not referred or referred but didn't show a completed colonoscopy. So about 30% declined colonoscopy before the referral and 28% declined after the referral. Some patients were unable to reach. Some reported a prior colonoscopy, so follow-up may not have been needed. And the first two lines, the no reason indicated and the patient decline line, are the patients for whom an intervention like patient navigation could be most effective. And we were able to conduct qualitative interviews among patients and providers, and we found that providers and patients both identified barriers in coordinating patient logistical issues, such as arranging a ride and taking time off of work, as well as identified barriers in the cost of the colonoscopy and also confusion about the colonoscopy process. Why did they need a colonoscopy? They just screened by FIT. But providers also identified barriers of patients not really understanding the bowel prep, there were billing issues, and patients reported fears. And patients reported delays in getting an appointment and concerns with having multiple health issues at the same time. And all of these barriers can be addressed through patient navigation, and I know that Andy explained that last week. We found that more patients with commercial insurance or Medicaid completed their colonoscopy compared to patients with Medicare, patients who were uninsured, or patients who we just didn't know their insurance status. And so we've come up with some strategies and interventions in order to increase colonoscopy follow-up. So some of the strategies could include creating a registry of patients that need an intervention to try to get their colonoscopy completed, try to determine which groups of patients are at high risk, and also communicating with GI clinics. And some of the interventions that we've used and continue to use are motivational interviewing with the patients, reminders for getting that colonoscopy, patient navigation, and a provider having that conversation with the patient about the importance of having that follow-up colonoscopy. So to create a registry, you may want to winnow the targets for patient navigation or for whatever intervention you decide. You could simply select the patients who screen positive on a FIT test. You could look at the patients who've never had a prior colonoscopy, because this is a new process for them, who don't have an appointment scheduled within a few weeks of the referral. You could ask your providers to assess the patient to see if they are resistant, and in that case, refer them onto an intervention like navigation. Or you could create a risk prediction model, which I'll describe in the next few slides. And some of the advantages of the risk prediction model are that it represents an unbiased way of delivering an intervention like navigation, and it can allow for immediate navigation delivery to those patients who need it the most. So with our risk prediction model, we chose to use patient navigation as the follow-up intervention, and it's endorsed by national organizations. And for all of these studies, these random colonoscopy completion by at least interventions can be expensive, and not all patients need assistance to get their colonoscopy. So first, identifying those patients with a positive FIT test, and then determine who needs those interventions through registries or through risk prediction. And determine, based on your patient population, who needs navigation. Learn from your patients, why aren't they following up, and adjust your interventions to address those issues if they're consistent or common. So we knew that there was a fundamental problem of trying to get people to follow up, and we wanted to identify the patients with the low to moderate probability of completing that follow-up colonoscopy. And we wanted to identify those who needed patient navigation because it is expensive and time-consuming. So this funnel on the right really shows the way that we've removed offering patient navigation to all patients. Rather, we really identified those with that low to moderate probability. So our risk prediction model was created through the PRECISE project, and we think it might give you some ideas on how to winnow your targeted population. So this project is a partnership between the Kaiser Center for Health Research and the CMAR Community Health Centers in Washington State. It's a two-phase patient randomized trial of patient navigation versus usual care. And we're aiming to enroll 1,200 patients across 28 CMAR clinics. And it's a 5-year study funded by the National Cancer Institute. And we're actually looking at 6 months. We're assessing the cost of the program and the return on investment of the phone-based patient navigation program. And we're assessing some secondary outcomes as well, like the time to colonoscopy, how many missed appointments in patient navigation versus usual care, and the colonoscopy quality, especially the bowel prep. And we'll look at some moderators by the probability of getting their colonoscopy. The study design is in 2 phases. As I mentioned, phase 1 is validating the risk model. We assess the patient's risk, and then we adapted the patient navigation material to be applicable to CMAR community health centers. And in phase 2, which where we are now, we're in the process of identifying patients with positive fit, assessing their colonoscopy risk of not completing it, and we're applying a phone-based navigation delivered. We're actually delivering it by an MA instead of by a nurse to reduce costs. And we're applying that to usual care. And our primary outcomes are the receipt of a colonoscopy within a year of their positive fit test, and we're also looking at 6 months, and we're also doing the economic evaluation. So CMAR Community Health Center serves about 300,000 patients. They have about 32 primary care clinics in Western Washington, about 40% Hispanic population. You can see here that their health centers span from the Canadian border down to the Oregon border. And they already have implemented a mail fit outreach program. They're mailing about 12,000 kits a year. And they have roughly 700 patients who screen positive on their fit test each year. But their follow-up colonoscopy rate is only 44%. So they knew, and we knew, that we needed to test out some interventions to increase that follow-up colonoscopy rate. The benchmark set by Prosper is 90 days, and only 22.9% of the CMAR patients were getting their colonoscopies within 90 days. So we're hoping to increase that percentage and shrink the time to colonoscopy at CMAR. Oh, I should also mention that they are using the OC Micro Fit test, which is processed on site using a centralized laboratory. So it's an in-house lab. The steps at CMAR clinics and with their specialists in Washington State typically we're identifying the abnormal fit results. The patient gets the referral to the gastroenterologist, which includes about 130 different gastroenterology offices in Washington. Many of the offices are starting to require a pre-procedure visit prior to the colonoscopy, and then finally they get their colonoscopy. And in our baseline analysis of the first year of data before the project started, we found about 715 patients with abnormal results. About 89% got their referral to gastroenterology. Only 52% completed a pre-proc visit, and only 44% of those 715 patients actually completed their colonoscopy. And you can see at each step where there are gaps that could be closed. So we had to understand the reasons for non-completion. We found these through chart review of those 715 patients with abnormal tests. We found that sometimes there's just no follow-up by the patient. The CMAR would call them to try to schedule a referral, but the patient never called back. Different than just couldn't reach the patient, couldn't leave a message, couldn't ask them to call back. Oftentimes the patient just declined and said, no, I don't want to get a colonoscopy. Sometimes a referral just didn't happen for unknown reasons. Some patients had other health concerns that they didn't want to get the colonoscopy at that time. Sometimes the patient no-showed to the appointment. And sometimes providers were giving the patient a second fit instead of forwarding them on to colonoscopy, which we know is inappropriate. And sometimes we didn't know why patients weren't getting their colonoscopy. So this was about 381 patients with no follow-up, no colonoscopy. So barriers aren't just at the level of patients. We know that GI facilities also presented barriers, and understanding the policies of the GI offices to which you're referring your patients is really important. So some GI practices differ by, first, whether they take Medicaid patients at all, and how they prioritize patients by coverage. We've heard that some clinics have limited numbers of slots for Medicaid patients. It's also interesting to understand whether they will prioritize scheduling patients who are FIT positive. We found that many clinics do prioritize those patients over regular screening colonoscopies because it is more urgent. And we've also found that having conversations with GI offices can sometimes make that a policy or a priority. Some GI offices require the pre-proc visit, which we're studying. The pre-proc visit does help get the procedure completed, but it might also be a barrier for patients. So we're trying to learn more about the pre-procedure visits and really help our patients get to those visits when it is required. The GI offices vary in their transportation policies, whether they allow a patient to come by taxi or by a ride share if they need to have an escort. And some of them have very specific policies about somebody being there the entire time with them to give them a ride home. And also, colonoscopy prep varies widely by GI clinics, so understanding which preps are required at different clinics is important. So we created a risk prediction model identifying patients with abnormal FIT tests, and we sought to determine which factors determine their likelihood of completing that follow-up colonoscopy. And our model among the precise patients showed that younger patients are more likely to get their colonoscopy, non-minorities are more likely, people with good insurance are more likely, patients with missed appointments might have a missed colonoscopy. The Gagny comorbidity score is a way to measure, different comorbid conditions that patients might have, and people with more conditions are more unlikely to get their colonoscopy. Higher BMI, patients are more unlikely to get their colonoscopy. If somebody has a partner, then they are much more likely to get their colonoscopy. That support system and sometimes maybe pressure to get it done. If a patient has had prior CRC screening, they're more likely to get their colonoscopy. Women are more likely, and women who have screened by mammogram in the past are much more likely. And English-speaking patients are more likely to get their follow-up colonoscopy. And then we also suggest you look at rates. In CMAR, there was variation by county. Look at the rates in your clinic by geographic area to see if there are gaps in different areas and if those can be addressed, because it could be GI policy or access to GI providers in those areas, and that's a different conversation in trying to get those colonoscopies completed. So we use the New Hampshire Patient Navigation Program as an intervention for PRECISE. So we identified our list of patients who needed the patient navigation help, and patient navigation allowed us to work with patients to remove barriers. It also allowed us to work with the GI offices to identify policies and procedures, and that helped us get those colonoscopies done within 90 days. So the core elements of the patient navigation model include having a patient navigator that understands the medical issues, that demonstrates respect and empathy and is sensitive to cultural issues in your community. And our navigator is able to juggle patients at different stages of the navigation process. At any given time, she might have 100 patients, some of whom are just trying to get their colonoscopy scheduled, and some of whom are trying to make sure that their bowel prep is correct for their colonoscopy the next day. We also identified clinical champions within the CMAR Center, and these are committed advocates for the program's vision. And this champion really possesses leadership and passion and shares this expertise among the clinic and also gives medical oversight. So our navigator is able to work with the clinician if there is guidance needed about the appropriateness of the colonoscopy or if there are comorbid conditions that need to be addressed. So I mentioned earlier that we're no longer using a nurse navigator because it was too expensive and we were trying to reduce the cost. So because our navigator is a care coordinator and typically it's been an MA, having access to the providers. We have a provider within CMAR and also a GI specialist that is able to give that expertise. We schedule weekly meetings between the navigator and this medical oversight, and it's not needed every week. Now that we've been going through this for over a year, it's needed very rarely, but occasionally there is that patient that does have existing conditions that need to be discussed for appropriateness. We also developed some really strong partnerships with GI practices and community-based partners. GI practices, we found that there's portals and ability to get information, electronic information, to share information about patients with some of the GI practices. And with others, we just need to have a conversation with the GI office as we're sending in a patient. So those partnerships are really important. And then I'll briefly talk about the 6-topic protocol for patient navigation. I think Andy talked about it next week, but I'll touch on it again. It really is based on the patient education about the procedure, assessing the barriers and trying to help the patient resolve those barriers, and coaching the patient and supporting them. And really the content is much more important than the number of calls. You might be able to assess barriers in one call with one patient, but you might need repeat calls with other patients. And then, of course, for the research and for the health system, assuring that the data is entered accurately so that we can understand how the intervention is getting implemented and how that it's being carried out is really important for us to understand the effectiveness. So the patient navigation, the New Hampshire program, is based on the 6-topic protocol, and it is really set on developing a relationship with the patient and identifying the barriers that they might be facing. So within 5 to 7 days of understanding that they have an abnormal test, the navigator tries to have a conversation and educate the patient about the prep that's coming up and assess the barriers that they might be facing. And then the second topic, which might be a new call, is confirming that the patient has an appointment, discussing that pre-procedure if it's required, addressing their barriers, and sometimes addressing those barriers does take multiple calls. The third call, or the third topic, is typically 1 to 2 days before they start the prep to make sure that they were able to purchase all of the prep materials, which can be kind of confusing for patients. Reviewing the instructions and reassessing the barriers for the patient. Is their ride still in place? Are they able to take time off of work, etc.? And then the evening before the colonoscopy, the navigator calls the patient to discuss the bowel prep, see how it's going, review the next instructions for the next day, and confirm the appointment details. And if for some reason the bowel prep isn't going well, then the navigator is able to help them reschedule their appointment. The day of the colonoscopy, we typically try to check in really within a couple of days to check in on the patient, make sure they're doing okay. And then the wrap up is just checking that they got their results and also understanding that they understand their results and what their future screening interval might be, and also if they are getting follow-up care if necessary. So the New Hampshire Patient Navigation Program found that the navigated patients are about 11 times more likely to complete the colonoscopy than non-navigated patients. They're 40 times less likely to miss the appointment and 6 times more likely to have adequate bowel prep. And the navigator, in our case, was hired by the health system. As I mentioned, she's an MA. She has full access to the medical record. And The patient consent is waived because this navigator is embedded within the system, and this is a pragmatic study where we're observing them implementing this process. The navigator uses the registry. In this case, it's a list of randomized patients, and communicates with the patient and the GI practices. Our navigator is bilingual, and she works evenings and weekends to accommodate the patients when they're able to get calls. She's had extensive training, not only in what colorectal cancer is and what clinical factors might be present for the patients, but also we've trained her in motivational interviewing and the data entry. And we do ongoing feedback and booster trainings. We listen in on calls and give her feedback. We have a patient navigator that is able to give advice to her, a seasoned navigator. We also review the data to make sure that different events are getting entered appropriately. And then, as in any clinic, there is always turnover. So we always have backup staff, and we're always training new staff just in case, even when the navigator needs to take vacations or time off. So the evaluation plan for PRECISE is to, our primary outcomes are the effectiveness, the cost, and the return on investment. Our secondary outcomes are the time to colonoscopy, whether there's a decrease in missed or canceled appointments, the quality of the colonoscopy with bowel prep, and we're assessing the moderators. But our additional outcomes of interest are understanding the reach, how many patients are reached, and the actual implementation of the project. So I'll talk about that for a second. We worked with Dr. Peggy Cannon and Allison Cole at the University of Washington in a patient navigation replication study. And the data that I'm showing here is from the Delaware site. And what you see is that 402 patients were identified and assigned to patient navigation. They were only able to contact 186 patients, 116 were eligible, and only 72 agreed to participate. So that's 18% of patients that were assigned to navigation that were actually reached, or 22% if you only look at the patients that were eligible. And what this means is that we really knew that we needed to pay some attention on how to get a hold of these patients and to reach them, or else we wouldn't be successful in assigning the navigation. And as for implementation, we're really studying the adaptations, like the fact that they hired an MA instead of a nurse, which is an adaptation that might be able to eliminate costs. We're also interested in adaptations from the viewpoints of the primary care providers and the GI practices. We're interviewing patients. We already have really great feedback that the patients love this program. They love the navigator. They love the reassurance that their prep is going well, and it gives them more confidence going into their appointments for their colonoscopy. We're assessing the fidelity, how many of the topics of the patient navigation program are getting addressed by the navigator, and we're hoping that the fidelity really shows the success of the program. And we're assessing the processes for updating the EHR, communicating with the care team and the GI practices, because when you refer to a specialty clinic, we've noticed that there is a delay in information oftentimes coming back from the GI clinic, and the primary care providers understanding what's going on with the patient. There are gaps in the care providers understanding what's going on with patients. So I did want to mention the potential for partnerships with Lyft and Uber. We have created a partnership with Lyft for this project, and Lyft and Uber both have community grants and other awards that typically up to about $20,000 in rideshare credits. And CMAR is using Lyft to get patients to and from pre-procedures, as well as colonoscopy appointments if there are issues with transportation. So I'm going to show you a couple of examples of some of the materials that we're using. This is simply a fact sheet for the patient that shows the importance of getting screened. What is colon cancer? Why should I get tested? And how do I get tested? This gets mailed to the patient when we first identify them as having an abnormal test, just so they know the importance of getting that follow-up colonoscopy. They also get a how do I prepare sheet that really outlines the steps for the bowel prep and the procedure for getting ready for the colonoscopy. The And these are all available on our website, which is nailedfit.org, and you're welcome to take or use any of them. The final document that we share with the patient is really what is patient navigation. And this actually is a picture of our navigator at the bottom. Her name is Dee Torres, and it shows what she's going to be talking to the patient about, talking about scheduling, her support and bowel prep, and checking in about the colonoscopy and the results. And I think this we have found is really helpful for the patients to put a face with who is calling them and their reason behind each call. So some of our initial results were we started randomizing in August. We found 300 patients with abnormal FIT tests, and 14 patients were excluded through electronic years. And if a patient has had a colonoscopy in the past 3 years, they may not need a follow-up colonoscopy. So those patients go back to their provider to discuss the conversation if a colonoscopy is actually necessary. So of the 286 found, each week our navigator does a scrub of the chart, and she has excluded 37 patients, and that's about 13% of our patients. Most of our patients are getting excluded because they have other medical conditions, such as they're on hospice or they have another cancer, and really a colonoscopy just isn't appropriate. That's about 32% of the exclusion. Another 30% is because patients have had a recent colonoscopy that was not picked up by codes in the EHR. So the navigator found a scanned document or a note that said that the patient may have had a colonoscopy at another institution, but we didn't have that discrete code to exclude them. So again, they got sent back to the provider to have a conversation if colonoscopy is actually appropriate. We found that some patients really were ineligible for FIT tests. They had other symptoms, or they were under some kind of surveillance for polyps. So they shouldn't have gotten a FIT test in the first place. So we send them back to the provider. And then we found one patient, which is about 3% of our population, that had moved out of the area or just wasn't, a patient at CMAR anymore. So now we have 122 patients that are being navigated and 127 patients that we're observing in usual care. So in conclusion, we know that risk prediction modeling shows promise for selecting patients for navigation, but we know that it can be further improved. We hope to improve our risk model by including some data that we didn't have available at the time, including community level data about community level factors like how many GI providers are in that area, what are the current weights, etc. Also, we're really wanting to include more patient-reported data like social determinants of health that just isn't available at this point in time. Data quality is really critical, and data quality and understanding your patients and reasons that they don't go on to colonoscopy can really help. We hope that future research considers risk prediction for other screening follow-up outcomes, breast, cervical, etc. So we know that we need to look at the patients with positive FIT tests first. First, we need to find that list and assess who might need navigation. And Gloria loves this slide because this really shows who should you give a hat to in this population. Some programs give a hat to all patients, and some programs give hats to those who already have one. And we think that we should try to give hats only to the patients that need one. And to do that, we recommend you create a registry, you learn from your patients, identify barriers at all levels, the patient level, the provider level, the GI level. You communicate with GI practices, and you try to get those colonoscopies done within 90 days. And that's it. Thank you so much.
Thank you so much. We really appreciate you presenting for us today. And thank you to everyone just for having some patience with our fun technical difficulties. I do want to say that the chat should be up and running now. So if you have any questions, we welcome you to type them in. And of course, you are welcome to unmute yourself if that is easier for you. If there's anything else, please just reach out to me. We will also have an evaluation, so please keep your eye out for the link for that. So I'm going to go ahead and just give it a minute and see if there's any questions that come in. Okay, it's a quiet group today.
Wow.
I am very impressed. Thank you to those of you who joined. I know that things are very chaotic and all over the place, so your ability to join us today is very appreciated. Oh, we do have a couple things coming in here. So the first thing I see, you mentioned that number of calls wasn't as important as content for the PN calls. Can you please expand on that?
You bet. Yeah. So the content of the conversation, if the patient navigator is able to really address those barriers in one call, then that's great. But if she needs to follow up, so having that conversation sometimes might include, do you have a companion that can attend the colonoscopy with you? And the patient might say, no, I don't. And then the navigator might suggest, do you have a neighbor? Do you have a relative? Do you have, a child that might, not a young child, but an adult child that might be able to accompany them? And then call back. So the content really is important in just covering all of those barriers, making sure that each barrier is addressed and recognizing when there might be a barrier that might pop up again. We often see that taking time off of work can sometimes be challenging. Working with them to try to schedule an appointment that's convenient enough that they have to take less time off of work is important. So yeah, it's the number of calls, sometimes it's many and sometimes it's few. It just depends on the barriers. I see, has your patient navigator had to work with patients in rural locations 1+ hours from the GI clinic? Yes. So in Washington, while a lot of our colonoscopies are happening in King County, which is the Seattle area, we do have a lot of very rural areas, especially areas at the coast. And again, I think Dee gets really creative with scheduling to try to make sure that there is time for somebody to drive, that they do have that escort or that transportation to get them there at a later appointment in case if they are far away. I know some patients have expressed issues with bowel prep and having to be in a car. If they do have the ability, they can stay over the night before. Some patients feel more comfortable with that. But really, it's working with patient on their resources. CMAR also uses a lot of their resources to help patients, put them up in a hotel the night before if they have to, etc. But really trying to get that bowel prep really solid, especially for these patients where it's difficult for them to go in and get that colonoscopy completed. Does that answer your question? I know it's hard because everybody's on mute. I'll also say that we have temporarily paused our randomization for this project. As you all probably know, the Seattle area is inundated with COVID-19, and we just couldn't recommend that our patients go in for colonoscopy. So we're going to wait for a couple months and make sure that the health system is back up and running again. But this is definitely something that was unexpected and we're adjusting. But I'm sure that it's on everybody's mind right now that it's difficult to send patients in for their colonoscopy when it might be putting them at risk of getting exposed. So just to let you know, we're on a temporary hold, but we hope to be back at it in June with patients really motivated to get their colonoscopies.
Thank you so much, Amanda. Is there any other questions? We'll go with another minute just in case someone is typing in. I know that takes a second. And Elsa did put the evaluation link in the chat. So please, if you could take a moment right now, it's just a couple questions. Will only take you 2 minutes to fill out that evaluation. It really helps us in our planning moving forward.
Yeah, I was also going to just pull up the mailfit.org website to show everybody where some of our materials are. Let me see if I can share this.
Yes, please do if you can.
Okay. Let's see here. Can you guys see this?
Yes.
Okay, great. So if you click on our research projects, there's a description of each of our projects, and under each you can click on the materials, or you can just go to the program materials. We have a lot of our MailFit resources, including introductory letters and scripts for reminders, etc. But for the Precise project, we have English and Spanish versions of each of our letters. And we also have English and Russian because we have a large Russian population in Washington State. And each of the documents that I explained earlier is there. And we love when people use our materials. They're funded by NCI. And if you do use them, we would love to be able to count that you've used them. So in our reports back to NCI, so if you do use them, just drop me a note just so we can know that they're being used. This is I think my favorite document. How do I prepare for my colonoscopy document that is sent to the patient? This is possible to put the date 5 to 7 days before your actual procedure date, so the patient knows when to stop taking iron supplements, to stop eating foods like nuts and seeds, and then to start their extended bowel prep. And then the day before, I love this picture here because it really clarifies what color their stool should be for an adequate colonoscopy prep. Yeah, so help yourself to any materials on our website for any of our projects. They're available. And then my email and Gloria's email is on this web page as well if you have any questions.
Wonderful. I appreciate that. And it's good to see things in other languages. That's always a barrier sometimes, is, not having access for everyone. So that
Definitely.
is a huge help. I'm glad to see that. I haven't seen any other questions come in. So I just want to take a minute to thank Amanda for taking your time and presenting for us today. We really appreciate it. Again, I know many of you are so busy and your colleagues are so busy, so we have this recording that will be available on our website for any of your colleagues who may have missed it. We'll make that available for everyone, and in our follow-up, we'll make sure to get the link to everyone. One last reminder to get that evaluation. And with that, I hope that all of you have a wonderful rest of your day.
Thank you, Amy.
Thank you. Take care, everyone.